they're going to come and like
Okay,
displace
welcome
MRI.
everybody. Thank you for making it this morning to our course on
Then
screening
just like an
and
ultrasound
early
machine.
detection of prostate cancer. So we have a few housekeeping rules that I will start with. And so this course is very interactive. We have 2 hours together. And if you have the app, there will be audience response questions in there. So we will have cases and questions. So please feel free to download the mobile app. And you can do that using the AUA website and use the email that you use to register for the AUA. And I should also state that AUA policy is that all authors and presenters must disclose to the AUA prior to their presentation all relevant financial relationships with any ACCME defined ineligible company, which is also known as commercial interest. And the AUA determines if the relationships are relevant to the educational content and mitigates any conflicts of interest prior to the educational activity. And disclosures of relevant financial relationships are posted on the AUA's annual meeting website at auanet.org. And a link is posted in the mobile app. And so some other housekeeping rules is to please remember to silence your cell phones. We don't want any phone calls or alarms going off during the course. And unfortunately, no photos, videos, or audio recordings are permitted during this course. And these courses are selected based on evaluation results. So we were very happy to hear your evaluations after the course. And for every course you complete, your name will be entered into a drawing for a complimentary registration to AUA 2025 in Las Vegas. So hopefully you can participate in that and hopefully you win. So that's all I had in terms of housekeeping rules. And we have here our distinguished faculty with me. And we will have a very fast-paced course and we will switch between the topics and cases. And we hope that you will enjoy this session. And feel free to ask questions. We have a microphone here at the front. And if you're watching this live, you can type questions in the AUA app and we will try to monitor the chat and answer your questions. Okay, great. So let's get started and put up our audience response questions. And you can scan this QR code and we will start with some pre-course questions. And after the course, we will ask you the same questions again. Okay, question number 1. What is shared decision making? Oh, we don't see the response. Oh, this is like a cliffhanger. I thought we would see the responses. Okay, we will see afterwards then. Thank you. Okay, so polling question number 2. Which of the following statements is true about consideration of previous biopsy before further management and repeat biopsy? Question number 3. A multiparametric prostate MRI is performed for an elevated PSA of 8.8. In which of the following scenarios should a systematic biopsy be performed? Question number 4. A 50-year-old man without any family history of prostate cancer agrees to undergo an initial prostate cancer screening with his primary care physician after shared decision making. His PSA comes back and it's 11. What is the best next step? Okay, number 5. Which of the following statements is false about prostate biopsy technique? Okay, great. Thank you so much for filling out the poll, and the results will be shown after the course. So with that, we will now move to the second talk. And I'm Sigrid Karlsson, by the way. I'm an epidemiologist at Memorial Sloan Kettering Cancer Center in New York, and I'm the course director for this course this year. And so next we will move to my colleague, Dr. Simpa Salami from Michigan, who is also our Golden Cystoscope Award winner this year. So congratulations.
Thanks, Dr. Carlson. So I thought that we'll start with a case this morning that you will reference throughout the entire course this morning. So you can go ahead and scan the QR code if you're not already in the system. So this is a patient, it's this 3-year-old patient who was referred to as essentially a healthy guy with no family history of prostate cancer, and you can see the trend in the PSA over the years. With his primary care, he had an MRI that was negative. So using the size of the prostate on the MRI, his PSA density was 0.2. Because his MRI was negative and suspicion for prostate cancer, he underwent a systematic biopsy that did not show any cancer, just atypia and ASAP. His PSA continued to rise, so this time his PSA density is now 0.42. It was repeated within a couple of 1 to 2 months, and the PSA still was elevated at 13.1. It is at this point that he was referred to us. So the question is, what would you do next? So this patient, here we presented 5 different options. Would you observe with your PSAs? Probably not, because his PSA remains elevated. Will you give antibiotics? No. As you learn later from my colleagues, antibiotics have not been shown to be useful in risk-stratifying patients who are at risk for prostate cancer. Would you repeat the MRI? He had an MRI within a year. So the question is, will repeating the MRI actually make any difference here? Probably not. So you're left with option C, biomarker testing, or repeat the biopsy. So I'll tell you what actually happened. So at the outside facility, they did repeat the MRI, still negative. PSA density 0.42. The MRI indicated that there's some features suggestive of prostatitis, so he got antibiotics at the outside hospital, but as you saw, it didn't really make any difference. So you'll learn why later. Antibiotics is not really useful in risk-stratifying patients at risk for prostate cancer. So when he got to us, what we did was to get a biomarker test. Locally at the University of Michigan, we have the MyProstate score, and this was suspicious for prostate cancer. And because he already had a negative systematic biopsy previously, we decided to use a different biopsy strategy, which was a saturation biopsy, a mini saturation biopsy, if you will. Obtained 26 cores, and as you can see, there were 4 cores that were positive for cancer, and they were all in the right anterior lateral part of the prostate, parts of the prostate that may be difficult to get to depending on what biopsy technique you use, and this showed grade group 3 prostate cancer, and then he went on to treatment. So with that, I will yield now to Dr. Sigrid Karlsson again, who will give the next talk.
Thank you. Thank you, Dr. Salami. So next we will have Dr. Scott Eggener from Chicago, and he's also the Mid-Career Award winner at this year's AUA for his contributions on screening and diagnosis of prostate cancer that he will now talk about.
All right, I'm going to throw out a bunch of thoughts. I'm going to mention a bunch of guideline statements, and as you all know, there are rarely occasions where there's absolute right or wrong answers. There certainly are some. I'm going to share my thoughts, and hopefully there's some utility to that. Is that good? There is nothing relevant that I'm going to go through. Some of these are distant disclosures, and the ones at the bottom are more recent, but I'm not even talking about these products. So, but I still think it's important for you to know about. None of these are relevant, but I still always push them out there because I think it's important. So the way I see prostate cancer screening, it's kind of the good, the bad, and the ugly. There are definitely some winning features to prostate cancer screening, most notably that since the PSA era started, there's been a 50% decrease in age-adjusted mortality, and that's a huge win. And we've got a lot of data to take a deep dive into. I would also be the first to say we should shout that from the rooftops, but we also need to be equally vocal about the bad and the ugly. There remains an epidemic or pandemic of just indiscriminate screening and silly decision making and an extraordinarily high likelihood of overdiagnosis and overtreatment. And it's become a very expensive space. The good news is we have a lot of new tools available that are, scientifically based, good evidence, but they're all very expensive, and we have to ask ourselves, what are we going to do? So as I mentioned earlier, death rates have gone down 50%, okay? That's a huge win. There are many men that have had their life saved primarily due to prostate cancer screening. There are also other reasons it came down, but the main factor was screening. And you can see it here kind of compared to some other cancers. You've all seen this before. I would also tell you the biggest win was amongst men of African ancestry, which is the greatest relative decrease in age-adjusted mortality. And so there are different racial and ethnic, breakdowns of how incidence and mortality, but you can see in that green the great decrease in mortality. The elephant in the room, and it shouldn't be an elephant, we should all be thinking about it when we're talking to our patients and talking about it publicly, is the need to save these lives but minimize overdetection and overtreatment. I would argue when you think of number needed to screen and number needed to diagnose, we're doing a pretty good job on par with our partners where things are more widely accepted. You probably saw there were updates in the breast cancer screening recommendations. If you look at it, the most optimistic that we have from the well-done trials is high quality compared to other things that are more commonly accepted. The issue is obviously the likelihood of side effects with treatment. And I say this, I've always said it sophomorically, but it is true. If the prostate was on our elbow, there would be no controversy whatsoever. You screen, diagnose, and aggressively treat everybody. I try to break this down on some tips that I use regularly and hopefully you either use or may consider. We have a big problem with screening old sick men with a really low value to prostate cancer screening. This is the AUA guideline that goes along with it, but basically use all the tools that you have available, usually cheap, easy, and sometimes even free, to decide whether they even need screening. So this was a study that one of our students put together close to 10 years ago. And it was almost literally jaw-dropping when I saw this data. This is from the entire country of the US, whether they had a screening PSA in the year before. And as you'll see, only about 40% of men get screened, but the rates of screening in 70 and 80-year-old men are higher than in 40 and 50-year-old men. It should really be the exact opposite. And it didn't really change much over time, over an 8-year window. I'd love to tell you we've known about this. Primary care does most screening, urology does a fair amount, but nowhere near as much as primary care. I'd love to say, hallelujah, kumbaya, there's been great progress. There's a paper that literally came out last week, and this was screening within the last 2 years based on age, and we haven't done much better. So my argument and part of my kind of academic mission is, if we can minimize overdetection and overtreatment, I do think there's a win in that more men would be screened. The ratio of benefit to risk becomes a lot better, and all of a sudden, whether it's guidelines or primary care doctors, find it more attractive. And then this is the disturbing thing and we saw this 10 years ago, even the sickest folks, with an estimated 10-year risk of mortality that you see there, a striking number of them are still getting a screening PSA. There are even studies in people with terminal cancers that are unlikely to live more than a couple years, and 20% of them are getting PSAs. It's ridiculous. And here's some other just kind of breakdown of the data that you can see, but you get my point. And I stopped screening a lot of men, and I'm going to give you some tangible info on it, but even just based on their life expectancy, it's okay to stop screening men and put it in their chart, a one-liner, and there's, basically zero legal risk to it all. So a 65-year-old US man, okay, what's the likelihood that they're going to live another 10, 15, 20 years? The average life expectancy from the sickest to the healthiest 65-year-old man is about 17 years. And average estimated life expectancy doesn't drop below 10 years until you get to 76 years old. So my point is, there are people in their 60s who aren't healthy that it's crazy to screen. There are also men in their mid to upper 70s that are perfectly healthy that are going to live a while that I am absolutely fine screening. The goals of screening are a little different than a perfectly healthy 50-year-old. So here's your guideline statement on shared decision making. I'm no exemplar of this also. I've tried to become better, but we need to do a better job of explaining kind of the good, the bad, and the ugly, or the risks and benefits of screening. If you ask men in polls who have been screened, what did your doctor tell you about it? Not surprisingly, we tend to make it simple and easy and just tell them all the potential good stuff and not necessarily discuss, some of the potential downstream effects. There are online shared decision-making tools that some people use. Maybe you use those in your practice. So be familiar with these modified guidelines. One of the wins of the updates of the guidelines is it's not that old school, everyone should be screened every year, and then the last iteration was every other year. There's a lot more flexibility now, and we need to become more like, colon cancer screening, where you get your first colonoscopy and they tell you to come back 1 year, 2 years, 5 years, 10 years. We can do the same, and I'm going to show you some data on that. Here are the updated guidelines. Unless it's a strikingly rare situation, you shouldn't be screening people less than 40. And then from age 40 to 45, anyone that's at putatively higher risk, and all the things, I don't have to go through them, consider a baseline PSA. There's wonderful data that I'm going to show you on the power of a baseline PSA before BPH becomes a confounder. We should offer regular prostate screening every 2 to 4 years for men in that roughly 50 to 70 year range. And I'm going to go through some things that help tweak the needle, more towards, every year, 2 years, 4 years. And personalize the rescreening interval. It's not just as simple as kind of age and what your PSA is. We've got a lot of other tools available that you can really personalize things. I always make the argument to our trainees, and whenever I talk publicly, I can't think of a single situation in screening, diagnosis, or post-treatment where I would change the recommendation or a plan based on one PSA alone. So almost always, I'm sure there's exceptions, but I would always repeat a change in the PSA before changing a game plan, particularly in the screening setting where there's so many other non-cancer related factors that can influence a PSA. I think JAMA should publish this every year as a reminder. Most people never knew about it or forgot about it, but it's over 20 years old. This is a colon polyp prevention trial where they had banked blood, and they looked at a definition of an elevated PSA, various definitions, and without any intervention, doing nothing in subsequent years, basically 40 to 50% of those men were back in the quote-unquote normal range. So I'm not telling you to wait a year or 2 years, but we all know and live through this and see it all the time, the fluctuation of PSA and the things that can confound it. So always, always repeat it. It doesn't matter if it's a month, like in the case, 2, 3 months, 6 months, whatever you think is appropriate. The half-life of PSA is about 2 to 3 days, so take that into consideration. Here's over a short window, over 2 months, and this hammers home the point. This was from Sweden, 1,600 men that ended up having a biopsy, but before the biopsy, they repeated the PSA. Let me walk you through the shaded area. That's what happened to their PSA. The peak in the middle is it basically stayed the same, and then there were some where it went lower and some where it went higher. And what's really interesting, and it's clinically actionable, is if a PSA is elevated, you repeat it and it stays elevated right at that level, that's the highest likelihood that they have Gleason 7 or grade group 2 or higher. If it keeps going higher and dramatically higher, that when you check it 2 months later, there's a pretty low likelihood they have it because there's likely something else. It's pretty darn rare for a prostate cancer to make someone's PSA rapidly go up in such short time span. And same goes if it goes down, obviously. That one's a little bit more self-evident. The PSA spikes up, you repeat it 2 months later, it comes down, they're going to have a way lower likelihood of having grade group 2. Hopefully you all know this. I'm still ashamed that I participated in this, but when I was a resident, everyone that came in with an elevated PSA got 4 weeks of Cipro empirically. I mean, we laugh at it now. The very first clinical trial I did as a young attending was to do a randomized study on Cipro versus nothing. It didn't make a difference. And then, not surprisingly, would present it at meetings like this. We gave, in the trial, 2 weeks of Cipro. And basically the feedback was, oh, you young ignoramus, you just don't know enough. You didn't give them enough Cipro. It takes a while to penetrate the prostate. So someone did a 6-week trial where they got 6 weeks of Cipro, and you know this, it didn't make a difference. And we know, obviously, that it's harmful. So use baseline PSA to risk stratify. Dr. Carlson's going to go through this. She's generated some of this data. It's extraordinarily powerful. So again, walking you through what can sometimes be a little bit of a confusing curve. So over 21,000 unscreened men, okay, they get a baseline PSA in their 40s, okay, and you see the gray curve there. That's the distribution. Almost all of them are quote unquote normal, but there's a wide range and a huge difference in your 40s if your PSA is 0.3, 0.8, or 1.5, and we need to pay attention to that. Separate from that graph, on the left, I drill into my head and try with our residents and fellows. Here are median PSAs by decade, and it's important to try to remember those. But back to the figure on the right, these are men in their 40s unscreened. Okay, so it's kind of a natural history because it was banked blood. And you can see even within those quote unquote normal ranges, that PSA level decades later predicts the likelihood of having any cancer or a potentially dangerous prostate cancer. So there is value in a baseline PSA. There was a lot of enthusiasm for many years on PSA velocity. It makes intuitive sense. It wasn't quite as simple and easy as, oh, if your PSA went up greater than 0.75, let's hop on that prostate and biopsy it. There's a lot more nuance to it. Here's a paper that came out a long time ago, and on the x-axis is PSA velocity. And yes, if you use a cut point of 0.75, it looks like PSA velocity is important. But as I already told you, the higher that PSA velocity is, meaning the higher the spike, the lower the likelihood that it's cancer. And you can see that there based on lower likelihood of cancer and a higher likelihood of inflammation on the biopsy. If you look at larger data sets from prospective clinical trials, the take-home message in both a huge US-based trial called PCPT as well as a European screening trial called ERSPC, if you take basic information about a patient being screened, total PSA, family history, DRE, whether they've ever had a biopsy before, PSA velocity does not add anything to your ability to predict a meaningful prostate cancer, because most of the PSA velocity is baked into the total PSA and some of those other features. So here it is from PCPT, here it is from ERSPC. I'm not going to run through it except to tell you, once you have all that other information, PSA velocity does not add much. I am a huge fan of free PSA. I order it on every single person that's getting screened. And in fact, for people with a mildly elevated PSA from 2.5 to 10, I am way more interested in what their free PSA is than what their total PSA is. And I want to show you some of that data. First of all, there's a lot of scientifically backed and very useful biomarkers. Most, not all of them, tend to be fairly expensive and send outs and you have to wait. Free PSA is in your lab on a research setting at $6. I don't know what insurance companies charge for it. Free PSA and total PSA are the main drivers of the 4K and the PHI. Mark Preston, who's done a lot of work on it with Dr. Carlson and others, likes to call it the 2K score. I kind of like it. Total PSA and free PSA. Very powerful. And here's just but one example. The only online risk calculator I routinely use in clinic is in a screening setting. But here's but one example that comes up all the time. You take a man with a PSA of 4, normal DRE, no family history, no previous biopsy. Based on their free PSA, there can be up to a 6-fold difference in their likelihood of having meaningful cancer, potentially meaningful cancer. So this gets back to, we all kind of, if you were like me, and maybe I'm outing myself, that first question on what is shared decision making is like, come on, we all know what that is, and we're all supposed to do it. But to me, this is shared decision making. This is kind of the essence of it, of trying to get granular data and more specific, and not just categorically say, oh, your PSA is over 4, we're going to do, a biopsy every time. Here's some data on free PSA. These are men from the screening trial in the United States. Median follow-up was basically 2 decades, and you can look at the breakdown here. There's a ton of other great data baked into these studies, but the take-home message is free PSA is extraordinarily powerful. And here's but an example, of just bringing out, baseline PSA as a total PSA, as a free PSA, and the likelihood of having meaningful events, decades down the road. PSA density. The great news is it's extraordinarily powerful. If we could start a company on PSA density based on the data, it should be the winner of all of the screening biomarkers in my book. Okay, it's not as sexy, it's not molecular, but it's extraordinarily powerful. It's mentioned 12 separate times in the guidelines. It's really powerful in screening and in active surveillance, which we're not going to talk about today. If you wanted to draw a graph about a terrific screening biomarker, look at that. Again, the gray, and going back to Sweden, is the distribution of PSA density in over 5,000 men, and that red line is exactly what you want. There's no step-offs, there's no ambiguity. The higher your PSA density is, the higher the likelihood you have a potentially meaningful cancer. DREs are not particularly powerful. We struggled when we put together the guidelines to come up with data that really supported DRE. Okay, I think I mentioned it at the end. But I find the greatest routine value to a DRE is, for me, estimating the prostate size. It's not nearly as accurate as ultrasound or MRI, but you have a pretty darn good idea if it's a 20, 50, 80, or 150 cc prostate. And that's a huge factor looking here at your PSA density. And here's the DRE. So I mentioned at the top, I think routinely there's value in estimating the size. There's obviously relatively rare patients that you're screening that you find a palpable abnormality. The take home of kind of the deep dive into the literature on DRE, and it's reflected in the guidelines, the only time it was really shown to be additive above and beyond PSA is once the PSA was greater than 3. So an abnormal DRE in the setting of someone with a PSA greater than 3 adds to the positive predictive value of finding a grade group 2 or higher. The evidence is pretty weak if you're routinely screening people with DRE when the PSA is less than 3. And lastly, know when to stop screening based on age and PSA. Amazing data, some of it generated from Dr. Carlson and her team. Huge swaths of people. So median PSA at age 60 is 1. So half the men at age 60 have a PSA less than 1. And in an unscreened population, followed for the next 25 years, if your PSA was less than 1 at age 60, the likelihood of you getting a metastasis from prostate cancer was 0.5%, and dying from prostate cancer was 0.2%. So, if there's anyone you want to dial back on, those would be the guys, okay? If you want to be really aggressive, screen them again in 5 years, or tell them at their PCP or to come back to you. Dr. Carlson also generated great data on if your PSA was above or below 2 at age 60. Remember, median's 1, but if you use 2 as a cut point, they were not able to show any benefit to screening if your PSA was less than 2. But it's rare you'll ever see a number needed to diagnose or a number needed to treat to save a life that's better than if you're screening people with a PSA greater than 2 at age 60. Because you've minimized some of the ultimately incidental diagnoses by eliminating people who have a baseline PSA that's pretty darn low. The other thing that's sometimes helpful, and when I read this study, I actually integrated it into my talks with patients. It sounds self-evident, but I got better at it after reading this study. Don't tell people you're too sick to be screened, you're not going to live long enough, that framing. You basically frame it in there's such a low likelihood it's going to be of benefit. There's an extraordinarily higher likelihood we're going to cause you harm or cause problems. So here's the summary of all the things that I threw out at you. Hopefully you find value in it. Again, I think proudly, most of these things are cheap, easy, and sometimes even free. I absolutely would recognize there are wonderful secondary biomarkers. You're going to hear about MRI, obviously biopsy is integral, but I think screening starts with this foundational kind of these elements to screening. So thanks.
Thank you, Dr. Egner, for this roadmap to screening. So number 4, please. And you will all get these slides. You probably already have them in your course package, so don't worry about taking notes or taking photos of everything, because they're all in your package. Great. And you also have there our full guideline of the AUA guideline for screening and early detection. Okay, so let's move on with PSA and isoforms and risk calculators, and more about risk-stratified screening, because that's really where the field is moving towards. And the first step, as you heard, is to always do shared decision making before you draw the blood, because it's the right thing to do. And we still recommend PSA as the first screening test. We've heard from Dr. Eggener about the extremely powerful value of PSA as a prognosticator of future lethal disease. And I can't think of any biomarker in oncology that's better than PSA for screening, early detection, and monitoring of treatment. So we're really blessed in urology to have the PSA test. So that's why we recommend this as the first test. And we have the evidence from our trials in Europe. I've been an investigator of ERSPC and the Göteborg trials that really shows that PSA screening reduces prostate cancer mortality by about 30% at more than 11 years of follow-up. And the PLCO trial here in the US first was interpreted as a negative trial, but as we all know, there was a lot of screening going on. And so when you take that into account, you also see a benefit of screening. So this has been shown in modeling studies. And it's also interesting to see that the CAP trial in the UK that just came out about 2 weeks ago and was presented at the EAU also shows that just a single invitation to PSA has an effect of prostate cancer mortality over 15 years. I was actually fairly surprised by this, but it just shows the point and the power of PSA. But we think that if you should do PSA screening, it should be more of a dynamic approach if you want to have a greater benefit. And Scott mentioned DRE. We have it as optional in our guideline. So some doctors might want to do it and some patients might ask for it, but it has its highest utility when the PSA is above 2. So it can definitely be part of screening, but it should more be part of the clinical workup. Should we put men straight into an MRI? That's another question that has been proposed. I personally think that the number needed to MRI for the yield, it will be too high, so we would recommend starting with the PSA, but it definitely can have some value. And in this trial in the UK, some of the men who had a PSA below 3 actually had some lesions. So that also shows, we need more studies about the cut point for further investigation. And there's another trial in Canada that also shows that using MRI can reduce unnecessary biopsy. So it's definitely part of the pathway, but we still think the PSA should be the first screening test. And here is data from the Göteborg 2 trial that's ongoing that then combines PSA with the MRI. And there are two arms. One has a cutoff of 1.8 and one with a 3. And going forward, just using the targeted biopsies to what you see on the MRI can then also reduce unnecessary biopsy and overdiagnosis. So I think this is an interesting pathway going forward. And the Stockholm 3 test is also one of these risk-stratified pathways. It's a multiplex test that combines clinical information and age, family history, and prior biopsy. And then going forward, using Stockholm 3 and MRI can again show kind of the trifecta of screening, if you will, with reduced unnecessary biopsy, keeping the detection of significant disease, and reducing overdiagnosis. And here's another study that also just came out 2 weeks ago and was presented at EAU by Dr. Auvinen. It's called the ProScreen trial in Finland, and it's kind of a hop, skip, and jump. So it's a 3-step trial combining PSA with a 4K score and then MRI, and also again showing the same concept of detecting high-grade disease and reducing overdiagnosis. And I think this trial is interesting in terms of the negative predictive value. So at each step, you can kind of reduce the number of men who continue in the screening pathway. So I think we need to think about that more when we think about screening. What about genetics? We will hear more about this from Dr. Salami and also about all the other biomarkers. It can have a value for some men. I don't think we're ready to have population-based screening based on genetics, but it can definitely be incorporated in the risk stratification. And when you add this to the Stockholm 3 test, you can see that it adds 1% to the AUC. And it's questionable if this will be feasible, as I said, on the population level. When you do this, there was a low uptake. But it has been said by some as a measure of kind of quantified family history, if you will, so it can have some utility. Although it's a high bar, as mentioned, the PSA test is so powerful that it's really hard to beat. So once you add the polygenic risk score above and beyond the PSA, it doesn't add to the prediction of the endpoint lethal disease. So we have a really good biomarker, but we can definitely add some with genetics, but perhaps not as much as we would have hoped. And we already talked about repeating the PSA, and I wanted to just emphasize and reiterate that's also a very simple thing you can do before referring men to biopsy. And baseline testing is, again, really powerful, starting in midlife. So once you know your baseline PSA level, and you can then stratify future risk. So you can modify the next rescreening interval to a man's age and his PSA level, and the multiple studies on this. Should you start at 45 versus 50? There's the ProBase trial in Germany that's ongoing, and it would really answer that question once and for all. So how many cancers would have progressed in the interim, or can you wait until 50? So what we learned from that trial so far is that it's prostate cancer is very rare among young men, and MRIs can be hard to interpret in young men, but the study is ongoing, and we will have to wait future follow-up to see if it's really beneficial to start at 45. Although we in our guideline recommend starting somewhere between 45 and 50, and of course younger, starting at 40 to 45 for men at increased risks of black ancestry, germline mutations, and strong family history. And how often should you screen? The ERSBC trial, which is a randomized trial, recommends every 2 to 4 years. It can be done at that frequency, it can be done annually. And all the studies show that over longer term follow-up, as Scott showed, the number needed to screen and diagnose really become favorable. And I think these numbers are really comparable to breast cancer screening, colorectal cancer screening. But as Scott mentioned, the prostate doesn't sit in the elbow, so that's why the guidelines perhaps disagree on the harms versus benefits. But in terms of mortality benefit, we really have the same numbers. And then you can personalize the rescreening interval. And as Scott mentioned, if a man has a PSA of 1 or less than 1 at age 60, he can go fishing basically because his risk is so low. We could also have a longer screening interval for those with lower levels. And then, of course, most bang for the buck, as mentioned, is for men with a PSA above 2, and those should be screened more frequently. Another powerful thing is to use a PSA for older men above 75 who have a PSA less than 3. They also have a low risk. And these are just some of the studies, and you can just see the beautiful separation of the curves, and PSA is really a strong risk stratifier in terms of prognostication. And in our guideline, we also have some cutoffs there by age for further evaluation with prostate biopsy. And it's important to note that the baseline PSA captures aggressive disease as well in white men as in black men with similar PSA distributions. And risk calculators, as we heard about, there are several out there, and they can help with biopsy decisions. And we have reviewed these in detail in our guidelines if you want to read more about them. And Dr. Salami will talk next about biomarkers. There's been an explosion on the market. There used to be only the PSA when I started working in this field, and it's been a really remarkable evolution. And of course, the new kid on the block that's made, it's a game changer in our field is, of course, the MRI. And these are also our biomarkers, and they are included in the guideline. And in brief, a review of all these biomarkers really show a clinical utility in, improving the detection of high-grade disease and avoiding necessary biopsy. And in terms of MRI, you all know of this, of course, there's massive variation in interpretation, and the negative predictive value is not 100%, so it can vary tremendously, depending on the center where you are. And so I like to say that a chain is only as strong as its weakest link. So for this concept to be successful of including MRI before biopsy, you really need to have access to high quality scanners and optimal reading of those scans, and training program for radiologists and high quality people performing the biopsy for this to be successful. So it's really important to have quality assurance programs. And finally, there are many ways to roam. How should we best screen? And there's a lot of studies ongoing right now. And here's just an example of ongoing or recently completed risk-stratified screening trials and pathways forward. So there are many ways we can do this. But you can see to the right that most of these studies incorporate PSA and MRI and some perhaps biomarkers and genetics in different combinations. And in EU, there's now a really interesting initiative called PRAISE-U. So EU has allocated money to 27 of the member states to explore different pilot programs of these pathways. So we will learn a lot about that in the coming years. So thank you. And now let's talk about biomarkers.
I think we're going to have you tease your brain a little bit here before we go into the biomarkers discussion. So go ahead and go back into your poll. So which of the following statements regarding prostate cancer early detection biomarkers is true? Okay, this is my disclosures that have no relevance to the talk that I'm giving today, but as you've already heard, we all serve on the AUA Prostate Cancer Early Detection Guidelines panel, and I also serve on the NCCN as well. Today, what we'll do is review the rationale for utilizing biomarkers in the early detection of prostate cancer. We'll discuss blood, urine, and tissue-based biomarkers that are currently available, and we'll go over the guideline recommendations for how to use these biomarkers in our practice algorithm, and then finish up with germline genetic testing. A biomarker, simply stated, is any molecule that is found in blood, urine, any body fluid that is a sign of a normal or an abnormal process. They can be prognostic or predictive. We're fortunate to have a number of biomarkers available in the prostate cancer space, both in the early detection space as well as in the advanced disease setting. And you've already heard about PSA, free PSA, and iso-PSA, and SOCOM3 as well, so I'm not going to go into those. So in the blood-based biomarker space, we'll cover a 5-score and a 4K score in a little bit more detail. So the 5-score is a blood-based test that combines 3 isoforms of PSA. I guess you can call it 3K. Is FDA approved, and in this particular study that was reported in 2015 by Dr. Loeb, a 5-score of less than 25 is associated with a lower risk of having any prostate cancer, a lower risk of having any aggressive prostate cancer. And what they also found is that the 5-score, which has the 3 components, outperformed any individual component of the 5-score. Essentially highlighting the fact that the more markers you have, the better able you may be in overcoming the heterogeneity that you may see in prostate cancer. The 4K score combines 4 different kallikreins and is also FDA approved, and is a model that includes the 4 kallikreins and age, DRE, and prior biopsy in the repeat biopsy setting. And what was reported in this multi-institutional study is the fact that the full model outperforms any model that leaves out one component. Again, highlighting the fact that potentially the more markers you have, the better the test might be. And what I try to do here is to illustrate the fact that the performance of the test depends on the cutoff or the threshold of the test. For example, for the 4K score, if you use a threshold of 9 or greater to identify patients for biopsy, you avoid 43% of biopsies. And what is interesting is what proportion of high-grade cancers you'll actually miss. In this case, 2.4%. And this is true with respect to majority of the biomarkers that are out there, is they can help avoid unnecessary biopsies and decrease the risk of missing aggressive prostate cancers. We'll switch gears to urine-based biomarkers. The very first one that was introduced to the market was PCA3. This is a long non-coding RNA that is expressed in urine. It's FDA approved for use in the repeat biopsy setting. And in this work that was led by Dr. John Way, a multi-institutional analysis, they found that if you use a PCA3 threshold of less than 20 in the repeat biopsy setting, it has a negative predictive value of 88%. And then when you add PCA3 to PCPT, Prostate Cancer Prevention Trial Risk Calculator, it performs better in both the initial and repeat biopsy setting. It's also better in identifying patients with aggressive prostate cancer as well as any cancers at all. But that was just a single biomarker. So further efforts have included adding additional biomarkers. In this particular work that was led by Dr. Tosoyan at Vanderbilt University, he and others developed the MyProstate score. Some of you might be familiar with it, previously known as the Michigan Prostate Score, or MIPS. Here they combined PCA3, TMPRSS2 against serum PSA. But the most recent iteration of the test was just published last month, actually, this time encompassing 18 different biomarkers. Some of these biomarkers that I shown in asterisk there are more associated with aggressive prostate cancer. And what they found was that using this test increased the sensitivity to 99%, negative predictive value to 99%, and you'll be able to avoid 35 to 46% of biopsies in the initial and repeat biopsy settings, respectively. Another test that has included PCA3 is ExosDS. This test does not require a DRE. This is the only urine-based test that does not require a DRE. It includes 3 different molecules, SPDF, ERG, and PCA3. And in this study, they correlated the ExosDS with the detection of grade group 2 prostate cancer or higher, and using a threshold of greater than 15.6 to identify patients for prostate biopsy, they reported that you can avoid 20% of negative biopsy, and you miss only 2% of grade group 2 prostate cancers, and no tumors greater than grade group 3 was missed if you use this threshold. And then the fourth and final urine-based test is SelectMDS. It combines DLX1 and HOXA6. This test is currently not FDA approved in the United States. And here they reported that if you combine these 2 different molecules with clinical factors and an area under curve of 0.90, which outperforms PSA or clinical risk factors in predicting aggressive prostate cancer. So moving to tissue-based tests, there's only one test in this space, and that is ConfirmMDx. So ConfirmMDx was developed under the premise that when you have, an area of cancer shown in red, that surrounding normal tissue may harbor molecular alterations that might inform you that you have missed a cancer area in the biopsy. So this test actually assessed the methylation status of 3 different genes listed here. And in this seminal study, 500 patients who underwent primary and secondary or repeat biopsy within 30 months, they performed the ConfirmMDx test in the initial biopsy tissue. And what they found was that all cases that were grade group 7 or, Gleason 7 or grade group 2 or higher in the repeat biopsies had methylation changes in their original biopsies. And they reported the negative predictive value to be 90%. And using this test, you can decrease your repeat biopsy rate by 64%. So this is a nice summary of the different biomarkers that we've discussed, so far. And what you see here, if it is legible enough, is that the performance are very similar. They all have very, similar area under curves, 0.7, 0.8, except ExosDS in the clinically significant prostate cancer setting with a an AUC of 0.66. In general, I think I stole this from Dr. Egner. In general, these biomarkers tend to decrease the need for biopsies or unnecessary biopsies by about 20 to 30%, and they also help minimize the detection of grade group 1 prostate cancers that we don't really care about. And importantly, you miss in general less than 5% of grade group 2 prostate cancers. However, these biomarkers have not been well validated in diverse patient population. Only a few of them have been tested in the Black patient population. And why is this important? We know, for example, that ERG has a lower expression in Black men, and this is a key component of EXOS-DS and the MyProstate score. So I think there is really a need to validate these biomarkers in diverse patient populations before you actually implement them in that patient population, if that's your practice. This is a nice summary of the settings that these biomarkers can be utilized, and as you can see, most of them can be used in the initial and repeat biopsy setting, except Confirm MDX, which requires a prior negative biopsy tissue, so it's only used in the repeat biopsy setting. So what do the guidelines say? In general, biomarkers are considered adjunct in the algorithm for evaluating patients at risk for prostate cancer. In the initial biopsy setting, this statement says that you may use urine or serum biomarkers when further risk stratification would influence the decision to proceed with prostate biopsy or not. So essentially, it is optional. In the repeat biopsy setting, if a patient has a low probability of harboring grade group 2 prostate cancer, for example, as Dr. Egner described, if the PSA density is low, say PSA density of 0.1 after a negative biopsy, you don't need a biomarker. However, if the risk of harboring aggressive prostate cancer is high, your PSA density is still high, like the case we presented at the very beginning, then you could use a biomarker to selectively identify those who may need to undergo further evaluation. And these recommendations are very similar to other guidelines, like the EAU also consider this, optional because they're not. We don't have sufficient data at this time to implement these biomarkers as routine tests in screening for prostate cancer. Again, very similar to the NCCN recommendation. They are considered, optional as well. So we need data on how to integrate biomarkers and MRI in our algorithm for evaluating patients who are at risk for prostate cancer. And this is a very nice study that Dr. Carlson, highlighted previously, where men were randomly assigned to screening versus no screening. And the data I'm going to show you here is in the screening arm. This was nicely summarized by Dr. Tsoyan. And essentially, when patients have elevated PSA, they get a biomarker test. Patients who have a PSA that is considered normal, they essentially get the green light. And if your PSA is elevated and your biomarker test, in this case, they use 4K score. If your 4K score is elevated, then you get an MRI. If MRI is positive, then you get a targeted biopsy only. If your MRI is negative, you don't get a green light, the yellow light or orange light. You need additional information. Again, what do we see? PSA density. So if PSA density is still elevated, then you get a systematic biopsy. I think this is a very nice algorithm highlighting how to implement biomarkers in evaluation of patients who are at risk for prostate cancer. So we need more studies like this, and this is another data that really highlights how effective this can be. When you compare the ProScreen trial with the ERSPC trial, the European screening trial, and you look at the first round of screening, the detection of grade group 2 to 5 prostate cancer, very similar. But to be able to get this, you would have to do more biopsies in the European screening trial. This is really, it highlights how impactful it can be to use PSA, biomarkers, MRI in your screening algorithm. Also noteworthy is the fact that you detect less grade group 1 prostate cancers if you use the algorithm incorporating PSA, biomarkers, and MRI. So we need more studies like this, and this is a study that is currently being led by Dr. John Way, in this case, looking at MRI with the MyProstate score at the University of Michigan. So when you have a patient before you, you want to consider a biomarker test, I think we need to ask ourselves important questions. Why am I getting the test? What information is it going to provide for me? Of course, we all want a test that will tell us, positive or negative, yes or no. But that's not what biomarkers do. They essentially present you with risk. So you need to have a plan of how you're going to utilize the results from that data, that test, before you actually order it. For example, you get a biomarker test result that says 10% risk of high-grade prostate cancer. A patient might be comfortable with that, of not undergoing biopsy. Whereas you may have other patients, they have 5% risk of having high-grade prostate cancer. They want a biopsy like right now. So you need to have a plan, discuss with your patient before you actually order the test. And then don't order too many tests, or order tests reflexively, because they all provide very similar information as we highlighted. And also ask yourself, is the biomarker of interest validated in a patient population that includes a patient like yours? How do I personally use biomarkers? Patients see biomarkers on TV, commercial, they want the test. I try to talk them out of it. If I don't think it's necessary, they still want it, fine. We'll get it as additional information. And it's also can be useful in counseling patients who are very anxious. They have low suspicion for high-grade cancer. They want the test. If the test comes back as low risk, that's reassuring. If a patient has a negative MRI, benign biopsy, still ongoing suspicion for high-grade prostate cancer, for example, PSA density is high, I'll order a biomarker before I proceed with additional evaluation. And if MRI shows a lesion and biopsy is negative, especially if it's like Paris 4 or 5 lesion and the biopsy is negative, I will consider a biomarker to make sure we're not missing anything. So this is the brain teaser that we had. So the answer is confirm MDX because it requires a prior negative biopsy. Okay, so that's the first part of my talk. So the second part is germline genetic testing. Majority of prostate cancers are sporadic, meaning that the exact cause of the cancer is unknown. And about 5 to 10% of prostate cancers are considered hereditary, meaning that there is a specific mutation or alteration like in BRCA1, BRCA2, or the Lynch syndrome mutations that put the patients at risk for developing prostate cancer. And 15 to 20% are familial, meaning there is some potential genetic association, but no detectable mutation has been found. Why is it important to keep this in mind when you evaluate patients? Well, germline genetic testing can provide information that can be used for risk assessment, can be used for prevention of certain cancers, can be used for establishing or determining prognosis. For example, patients with BRCA1, BRCA2 alterations who with low-grade disease are at higher risk of undergoing grade progression while on active surveillance. They could be used for treatment selection, for example, olaparib in the metastatic cancer space. And then it can also be used to guide additional testing of family members for prostate cancer as well as other cancers like breast, colon, or pancreatic. For example, patients with BRCA1, BRCA2 alterations have a 2 to 6-fold lifetime increased risk of developing prostate cancer, more so with BRCA2, 8.6-fold increased risk by the age of 65. These patients tend to have more aggressive disease, higher grade disease, lymph node metastasis, poor survival, and these patients may also be at risk of other cancers, as already mentioned. In the localized prostate cancer space, this was a paper that was reported out a few years ago where they looked at men with localized prostate cancer, and then they found that 17% of the men that were tested have a germline variant. Of course, there's some selection bias at play here because these patients underwent testing for a reason. But what is noteworthy is that of those that tested positive for a germline variant, 37% would not have been tested if you were to go by the NCCN guidelines at the time. So more recently, the guidelines, I think I'm just showing here that the distribution of these different germline variants are very similar to the metastatic disease space. So more recently, the guidelines have incorporated germline genetic testing in a simplified manner. In general, if a patient has low or intermediate risk disease but have a strong family history of prostate cancer, or there's intraductal or cribriform histology in the specimen, they should be considered for germline genetic testing. And then certainly if they have high-risk prostate cancer, you should consider germline genetic testing. And this starts with obtaining a detailed, family history, the who in the family, what kind of cancers, when, how were they when they were diagnosed, and how aggressive, was the cancer. And then, consider what tests do you order. In general, there's so many tests out there that looked at different panels of genes, some, just a handful, some tens of genes. But whatever test you decide to use, make sure that it's assessing the key genes that are associated with prostate cancer, like BRCA2, BRCA1, the Lynch syndrome mutations, and HOXP13. And specimens can be blood or saliva or even tissue, and the tests generally, are about $200 or so and may be covered by insurance. And if you have a positive germline variant, there will be no need to do somatic testing, since whatever alterations you find are also present in the somatic cells. Germline genetic testing can be clinician or urologist directed, or it can be a genetic counselor directed, but it should really be a team-based approach. Certainly, it's important to incorporate genetic counselors in your algorithm, because they will be able to help advise or recommend screening for other malignancies, and also oversee cascade testing of other family members. And certainly, if you self-direct germline genetic testing and you find a positive variant, you want to refer the patient to a genetic counselor for counseling. So in conclusion, I think it's important that we are familiar with what biomarkers are available in the early detection of prostate cancer space, understand what data each test provides, and make sure that the test is validated in a diverse patient population. And before you order a test, make sure that it's going to impact the decision that you make before you order it. Don't order tests, reflexively. Don't order too many tests, because they provide very similar information. And we need to keep up with emerging data, especially when it comes to integrating biomarkers with MRI. And patients that are eligible for germline genetic testing should be considered for germline testing. With that, I'll say thank you.
Thank you so much, Dr. Salami. That was an outstanding overview. So now we have gone through PSA screening, biomarkers, risk stratification, and we will now move into where AUA becomes AURA, the American Uroradiological Association, moving into MRI and biopsy techniques. So we will hear from Dr. Dan Baracus at Vanderbilt and Dr. John Way from Michigan.
Thank you all for attending this course. I'm going to take 1 minute before I start to brag about this course for a second. This is the longest running course that the AUA offers. I myself have been doing this for about 15 years, and over the course of time we've accumulated a faculty of presenters much smarter than me, but all of us are on the AUA guideline panel for early detection for prostate cancer, some on the NCCN guideline as well. But importantly, maybe not myself, but the four of these folks are not just evaluating the data, but generating the data, and true thought leaders in this space. And as Dr. Carlson mentioned, of the handful of major awards this year, we have on this panel the Gold Cystoscope Award winner and the Mid-Career Award winner. So thank you for attending. I'm delighted to see that this course is still well attended. It is shaped not just by the data, but by your feedback. So we really this course has evolved a ton since I started. And so please do fill out your evaluations. We really read that stuff and incorporate it. So talking about the role of, let's see. I'm unable to advance using this. Should I use? Okay. All right. So I have no relevant industry relationships, although my full list of disclosures is available on the AUA website. The learning objective here is to explain and implement the AUA guidelines concerning use of MRI for prostate cancer detection, both in the initial biopsy setting and repeat biopsy setting. What is the rationale for using MRI in prostate cancer diagnosis? I think you all know it, but I'll review it very briefly. The evolution here is from finger-guided biopsy to ultrasound-guided biopsy, and now MRI. MRI can be used to guide biopsies, so-called in bore, right, in the MRI scanner, or by cognitive registration, meaning looking at the MRI and then performing your ultrasound-guided biopsy, or using computer-assisted fusion of the MRI and biopsy, MRI and ultrasound images. And of course, MRI could be used whether you're doing it transperineally or transrectally. And as we heard previously, the guidelines are sort of agnostic as to the approach. Why would we use MRI to guide biopsy? So the obvious answer is to direct biopsies at regions of suspicion. Maybe we can also use it to avoid doing the systematic course. In other words, just biopsy the target. And maybe we can use it to avoid biopsies in patients with a negative MRI. And I'll talk to you about each of these in turn. From a statistics standpoint, directing biopsies at areas of suspicion increases sensitivity, right? We take a man with a PSA of 8, and if we do an MRI prior to biopsy and do both the targets and systematic cores, we are more likely to find a grade group 2 or higher prostate cancer than if we had only done systematic biopsies. When we talk about increasing specificity, what we're saying is maybe we can avoid doing the biopsy if the MRI is negative, acknowledging that we may miss some important cancers. So talking about MRI in the initial biopsy setting, I'll sort of give a case description here to use to think about. I don't think this is an audience response one, but a 58-year-old white man in excellent health, no family history of prostate cancer. He has stable, mild lower urinary tract symptoms, and his PSA this year is up to 5.4 from 2.8 about 2 years earlier. And per Scott's instructions, we have rechecked it, and it is 5.5 now. No nodules on the digital rectal exam. He has sort of normal-sized prostate, no prior biopsy. So the available next steps are things like observe with serial PSA, give empiric antibiotics, use additional biomarkers like the ones that were just discussed, do an MRI with a plan to proceed with a biopsy, regardless of result, do an MRI with a plan to proceed with biopsy if it's positive and observe if it's negative, or proceed with a biopsy without MRI prior. And we'll sort of take those in turn as we go through the algorithm. This is the algorithm from the guideline, which you can find online. What does it say? It says that, I'm going to go back for 1 second. It says that adjunctive biomarkers and prostate MRI are optional prior to an initial biopsy. And I'll go through that a little bit further. So observe with serial PSAs, I don't think many of us would do that, right? This is a young man. We didn't talk about he has no major health issues, and his PSA is certainly up. Empiric antibiotics, as Dr. Egner showed, are inappropriate. Additional biomarkers could be considered. That's an option. An MRI with a plan to biopsy could be considered. That's an option. And biopsy without MRI prior would also be an option. And I'll get into more detail as to why that second to last option is not recommended by the guideline. And that's what I would do, MRI with a plan to biopsy. So clinicians may use MRI prior to initial biopsy to increase the detection of grade group 2 prostate cancer, 2 or higher. And again, that's increasing sensitivity. How do we know about that? There are numerous studies in this space. These are some of the major ones, each one with a different study design, and that's why you see very different increases in sensitivity for grade group 2 or clinically significant prostate cancer. But the bottom line is that MRI increases sensitivity for clinically meaningful prostate cancer. How much does it do so? It's dependent on the PIRAD score, and I think many of you know this system already, and I'll show you an example in a bit. But basically, if PIRAD's 1 or 2 means low probability, and there the likelihood of finding clinically significant prostate cancer is only about 7%. And 3, 4, and 5, you can see go up from there. And what I would say about 3 is that PIRAD's 3 is that it's equivocal. It's about the same as a random biopsy, whereas 4 and 5 are truly increased probability of finding prostate cancer that's clinically significant. This is an important distinction that the guidelines make between the initial biopsy setting and the subsequent biopsy setting. For biopsy-naive patients who have a suspicious lesion on MRI, clinicians should perform targeted biopsies of the suspicious lesion and may also perform a systematic template biopsy. That implies that the systematic part of the biopsy is optional. So targeted biopsy required, systematic biopsy optional. And why is this? Target biopsy actually, on those 3 studies that I showed, target biopsy with systematic biopsy actually increases the likelihood of finding clinically significant prostate cancer, whereas targeted biopsy alone has about the same likelihood as finding clinically significant prostate cancer as systematic biopsy alone. It just does so with fewer biopsies. So targeted biopsy without systematic biopsy, the advantage of that is it can lower the chance of finding grade group 1 disease, which we'd really rather not find. If you have a clinic like mine where you see mostly prostate, you would buy into that. We really don't want to find more grade group 1 disease. So again, this is one of the guideline statements. How many biopsy cores do you need out of each target? At least 2, and probably after 3 there are diminishing returns. So with higher number of cores, you see increased detection of clinically significant disease, but the downsides are increased time, cost, potentially complications, and certainly detection of grade group 1 disease. Little incremental value with more than 3 cores per target. And importantly, for risk stratification, so if you're trying to distinguish, for example, between favorable intermediate risk disease and unfavorable intermediate risk disease, and you're calculating percentage of cores positive, all cores from the same target count as 1. All right, so now we're up to the initial biopsy. And for patients with an elevated risk of grade group 2 or higher prostate cancer, an absence of suspicious findings on MRI, clinicians should proceed with a systematic biopsy. So just to reiterate that or restate it, what we're saying is that in the initial biopsy setting, even if you have the negative MRI, you should proceed with a biopsy and do the systematic biopsy. And this is different in the repeat biopsy setting, which I'll show you in a few minutes. So here the systematic biopsy is required. Again, this is because of what we've alluded to before. The negative predictive value of MRI is about 91% for grade group 2 or higher prostate cancer, which implies that about 1 in 10 men with a negative MRI do in fact have grade group 2 or higher disease. And if you think about it, a lot of the biomarkers that Dr. Salami was describing set thresholds for consideration of biopsy around 7 or 8%. And so having about a 9, 10%, 11% risk of grade group 2 or higher prostate cancer in many settings is sufficient to prompt proceeding with a biopsy. What is a systematic biopsy? There's no perfect answer to that. We debated it a lot on the guideline panel, but concluded that it should include at least 12 cores distributed throughout the prostate, particularly with thorough sampling of the peripheral zone. So back to our case, the MRI now shows a PIRADS 5 lesion at the left mid-peripheral zone laterally. And I don't expect that you will leave this course with a full understanding of how to read prostate MRI, but I think it's important to have a basic understanding, particularly if you're in a setting where you don't know that your radiologist is an expert. Because some of these you have to discern for yourself. I mean, we're all fortunate to be at academic medical centers where there are people who do this all the time. But the basics are, I'm not going to turn so you can hear me, but the basics are in that top left panel on T2 weighted imaging, which is usually the most crisp and precise imaging. It looks the most like a CT scan, anatomical imaging. Regions of suspicion show up dark. And so you can see that there, that dark sort of blacked out or smudged area is suspicious. On diffusion-weighted imaging, it comes up bright, and it's basically that they're showing the restriction of diffusion of water through the tumor because of different density of the material. The ADC map is sort of the opposite. It'll show up dark on the ADC map. And then finally on the dynamic contrast enhanced images, where if you've seen these, you scroll through repeated cycles where they've given contrast and they're imaging it at various intervals, you'll see it begin to get bright quicker than the other areas. So this patient has a PIRADS5 lesion there on that left side. He undergoes transperineal biopsy with cognitive fusion and is found to have a high-grade prostate cancer. Notice that there are 3 out of 3 cores from the region of interest and then 4 out of 12 cores of the systematic cores, all on the left side. And again, please keep in mind that all of those cores from the region of interest, if we were trying to tally up the cores, all of them would count as one core. All right. That's the initial biopsy setting. I'm going to shift now to those with still relatively high suspicion for prostate cancer, but who have had a negative prior biopsy. So just a different case, 68-year-old African-American man, also in excellent health. His father had prostate cancer. He has no urinary symptoms. His PSA is 10.3, no nodules, 50-gram prostate. Had a previous systematic template biopsy that was negative. I think based on his risk characteristics here, you can tell that this patient is relatively high risk, right? African-American, older age, family history, elevated PSA. And so in patients who are undergoing repeat biopsy, where no prior MRI was performed, those patients should have an MRI, right? This patient had a negative biopsy without MRI. Now we should do the MRI in preparation for the second biopsy. So here the MRI is required, whereas in the initial biopsy setting, it's optional. So patient undergoes MRI. And why do we do this? Sorry about that. Why do we do this? In patients with a prior negative systematic biopsy who did not have an MRI, MRI will show a suspicious lesion, depending on what study you look at, from 1/3 to 90%. And the biopsy will be positive for any prostate cancer, which we really don't need to know about, but grade group 2 prostate cancer in between 20 and 60%. So it is crucial to do the MRI in this setting. Now, what about the systematic biopsy? For patients who do not have a suspicious lesion on MRI, clinicians may proceed with the systematic biopsy, implying it's optional. Somebody who's had a prior negative biopsy, you do the MRI, you don't find any areas of suspicion. Now we're saying that the systematic biopsy is optional. I would argue that in this particular case, that patient is high enough risk that we would proceed with the second biopsy, and maybe, as Dr. Salami was saying, I can't remember which one of you said, maybe go after it by a different approach. If the last one was transrectal, try this one, transperineal. Why do we say it's optional in this setting, the systematic biopsy? Because repeat biopsies detect fewer and less lethal cancers. So with each negative biopsy, your probability of finding something bad on the next biopsy is lower and lower. However, again, MRI can miss 10 to 15% of grade group 2 prostate cancer, grade group 2 or higher, clinically significant. So we decide whether to do biopsies based on other factors, such as PSA density, other biomarkers, and nomogram. How much time? I'm okay. Okay. So in patients undergoing repeat biopsy who have suspicion on MRI, clinicians should perform targeted biopsy and may also perform systematic biopsy. This is sort of the same as the recommendation for initial biopsy. And I won't belabor that, but cancer is found in the systematic cores 5 to 10% of the time in this setting. So in this case, MRI, if positive, we're going to do the targeted biopsy, that's required, and systematic biopsy is optional. If negative, the systematic biopsy is optional. Again, that's a little bit different. from the initial biopsy setting. I'll summarize that all at the end, and you'll have that a little summary table in your handout. What about the difference between cognitive fusion and computer fusion? Clinicians may use software registration of MRI and ultrasound images during fusion biopsy when available. What this means is that you don't have to send someone to an academic medical center with a fancy fusion machine where it's going to take a month to get in for a referral and another 2 months to get in for their biopsy. You can look at the MRI and do a cognitive fusion biopsy with very little risk that you're going to miss that lesion compared to doing it with computer fusion. And so there has not been much difference shown between cognitive fusion and computer fusion. It obviously adds cost. Those units are in the hundreds of thousands of dollars to purchase. This is just an example of a study from the UK with over 1,000 patients where all MRIs were read by expert GU radiologists. And basically there was very little difference between cognitive fusion and software fusion. It was not statistically significant. And so I don't think you're doing your patients a disservice if you don't have the availability of a computer fusion software. Here's that summary slide I was talking about. In the initial biopsy setting, MRI is optional, but in the repeat biopsy setting, it's required if it hasn't already been done. If the MRI is positive for both settings, we should hit the target, that's obvious, and the systematic cores are optional, recognizing that 10 to 15% of the time the MRI is failing to identify potentially grade group 2 or higher disease. When the MRI is negative, in the initial biopsy setting, you should still do that biopsy, whereas in the repeat biopsy setting, it is optional. Get 2 or more biopsies per target, and there's not much difference between computer software registration or cognitive registration. If it hasn't been said or hasn't been emphasized enough, these are guidelines, and clinical judgment trumps guidelines every time. And so, all of these are guardrails, but injecting your own judgment is always appropriate. That's all I have. Thank you for your attention.
Thank you so much, Dr. Barakas. And now our final talk in this course. We have half an hour left. It will be very practical, and Dr. Wei will share all his expertise on how to do a great prostate biopsy.
All right, morning everybody. I'm going to begin just so I know the audience that I'm speaking to. With show of hands, how many of you are doing transrectal ultrasound biopsy? About 70%. How many are just doing perineals? All right, and how many have done a perineal biopsy and found it too painful, too difficult, and they gave it up? Oh, all right, good, good. So what I'm going to talk about, my disclosures. We're going to talk about how to do a prostate biopsy safely. There's going to be emphasis on complications, particularly sepsis. We're going to talk about the rationale and how to go about doing a transperineal prostate biopsy. And the key really comes down to doing the proper anesthetic. Some of you may remember there's a time when we used to do sextant prostate biopsies. That's how we're trained. We didn't do more than that. And every single court, the patient would jump and scream, right? And then we started introducing lidocaine. And well, you could do 12 biopsies. You could do 20 biopsies, and patient would be still, right? So anesthetic is the key. So the safest biopsy is the one that got away, right? So the guidelines speak to this. There's 2 scenarios where you can avoid a biopsy. One, where you, including your clinical judgment and patient's risk factors and PSAs, of course, are so low that you deem it to be unnecessary to do a biopsy. And then the opposite scenario is true as well. So you can have a patient with a very high PSA, for instance, and for the AUA guidelines, we kind of arbitrarily picked 50, but think of it as a patient with a very high PSA where you go, he certainly has cancer. Maybe he even had a CT scan already that shows metastases. You go, that guy don't need a biopsy. So the guidelines put this recommendation in there to kind of give you cover For those patients, you go, he should just go on and start hormones, or he should just get treated. Let's not waste on biopsy. Maybe he's too sick. Maybe you would like make him septic and he won't tolerate it. Just go ahead and get him treated. All right, so next we're going to talk about what we tell patients about prostate biopsy. We begin with telling the patient why we do it, right? They got to know why. And the reason, of course, is to find high-grade prostate cancer, clinically significant prostate cancer, group grade 2 or higher. It's no longer just finding any prostate cancer. In the same measure, you have to explain to patients that there's a possibility of finding low-grade cancer. And I think it's worth taking time to explain to patients in this scenario that we may find a cancer that you do not need treatment, because that blows people's minds. So really? Yeah, that happens. And then you say to them, in that scenario, we will sort of be telling you you're going to get repeated biopsies and imaging and PSAs and maybe to no avail, because it really won't kill you. So you have to emphasize that to the patient, that they may be found to have a cancer that's not harmful, that we don't need to treat. Beyond that, I always cover with patients, actually my nurse does this, sort of like how to get prepared for the biopsy. I always tell guys, you do not need to fast. It's incredible how many patients think they have to fast. Do not fast. Come in, have your breakfast, lunch, drink your coffee or tea, whatever. Because if they come in and they're dehydrated, they fasten, they're more likely to faint on you, okay? And who needs that? Enemas. I don't do enemas. I don't tell my patients to do enemas, I should say. There's some who like to do, for transrectal biopsies, like to do betadine washes and stuff like that. And that does reduce sepsis to some amount, but I just say don't do any enemas. And my nurse also tells them, if possible, have someone come with you. Complications. This is worth going over with patients as well. Again, my nurse goes through all of this. We tell them about 24 hours, they're going to have some perineal discomfort. Hematuria, very common. The literature would say about 50%, some visible hematuria, usually for a few days. Sometimes you may have blood in the semen, right? And the literature, again, says about 50%. But what I emphasize to the guys is, it's going to last a long time. Don't call me in like 2, 3, 4 weeks that you still have blood, brown color, red color. It will happen, and it will take a long time for that to go away. Sepsis is the main complication that we're afraid of, right? And in the literature, it's been as high as 4.5%. This is for transrectal biopsies, not perineal biopsies. And we would certainly want to reduce that. Some men who already have problems with urinary symptoms particularly will have worsening of their urinary symptoms. This is just short time. We're talking maybe a week or so where the symptoms may get worse. Interestingly, urinary retention is generally rare, but can happen, but it's higher among perineal biopsies. It's not clear to me why that is, but it has been shown to be higher for transperineal biopsies. Mortality rate, of course, is very rare, practically zero. And erectile dysfunction, you have to watch where you put the needles, avoid going to the edge of the prostate where the neurovascular bundle is, avoid sticking the needle into a corpora body. And erectile dysfunction should be very rare. How do we do antibiotic prophylaxis? Now, as I go through the next set of slides, I'm going to have to be clear when I'm talking about transrectal or transperineal. We started this course only talking about transrectal, and then as transperineal came to be, we're sort of emphasizing that. The goal, of course, is to reduce sepsis, and we're talking about standard patients. You know, your healthy, walkie-talkie patient. They're not immunosuppressed. They don't have catheters indwelling and so forth. The common principles are you want to avoid sepsis by reducing, giving antibiotics to patients who already have Cipro-resistant E. coli. Okay, you could rely on local antibiotic resistance data, and you have to limit your antibiotic use for 24 hours. Okay, and this applies for both transrectal and transperineal, less than 24 hours. The AUA guidelines used to have a guidelines looking at prophylactic antibiotics. I think it's still available, although I found it hard to find it this time. For transrectal biopsies, it's considered class 3 case contaminated procedure. Every patient should get an antibiotic. They recommend a single dose of Cipro. Okay, if they can't take Cipro, you can give them a cephalosporin with aminoglycoside. And if they can't take that, then you could go to aztreonam or get an infectious disease. So that's one way, is you give everybody Cipro. Another way to minimize sepsis, and you see here the second bullet, doing a pre-biopsy rectal swab. We can also do formalin dips. And of course, the ultimate in reducing sepsis is going to be converting your method to doing a transperineal biopsy, by far shown to be the most effective way. Then you don't have to do any of these things. In fact, you probably don't have to give antibiotics. Here's a transrectal swab. Okay, it's not actually this big. The way you go about getting a transrectal culture is a Q-tip. Usually your laboratory will give you a little kit with a test tube. You swab, and you have to make sure you get deep enough. It can't just be the anal canal. You want to get actually, somewhere on the prostate itself. If you do a DRE before that and you got some poop on your glove, just swab that. That's just good enough. You send that to the lab, and the lab will give you a result whether or not there is Cipro-resistant E. coli. If there is, they'll also give you sensitivities, and you use the alternative antibiotics based on sensitivities. If the culture comes back negative, that is no Cipro-resistant E. coli, you use Cipro. And let's see. Let's say the patient comes in and they didn't get a rectal swab, or maybe your lab doesn't do it. The alternative way of managing that is you always give Cipro, just as recommended by the guidelines, and you add in parenteral aminoglycoside. For me, we use IM gentamicin. If you have IV, you could put IV in patients, so you give IV just the same. That does the same thing as a rectal swab. Formalin dipping, very interesting concept. The story is that in some clinics, this is where it came about, is urology. The urologist, rather, they didn't have a helper, they just take the needle, they swab it, not swab it, they just dip it inside each formalin jar to get rid of the sample off the needle. What they found, the observation, was that the sepsis rate became very, very low. So they did a study, and here's a study by ISA more than 10 years ago. They clearly show by just dipping the tip of your needle in formalin and then reusing that needle, that basically that kills the germs that ended up on the needle, so your sepsis rate goes down. What we practically do in my clinic is we dip it in the needle, the MA who helps me, they dip it in the formalin, then they dip it in saline so that the formalin isn't being put into the patient. Not that I know that that's harmful. And we have observed also very low sepsis rates. All right, transperineal approach, antibiotics to be used. Same sort of goal, avoiding sepsis, but you're covering a different type of flora, aren't you? You're no longer worried about the gram negatives. You're really worried about skin flora, gram positives, if you will. If you give an antibiotic, it'll be something like Keflex, something just to cover the skin flora. You could use doxycycline. There are many out there now, and there's emerging data here that says you don't have to use any antibiotics, okay? And I'm going to put a caveat on folks that don't want to use antibiotics. The key there is patients in the dorsal lithotomy, you prep the perineum. When you put in your transrectal probe, sometimes you have lube, which is not sterile. And when you put the probe in, patients clenching out, you have the lube come back up on the perineum. That contaminates everything, right? If that happens a lot to you, give antibiotics. That's what I do. If you can somehow keep that from happening and keep that field very clean, lube doesn't come on it once you've sterilized it, then go ahead, go without antibiotics. There's good data to say you can do that. Special cases, okay, where I would definitely give antibiotics. The American Orthopedic Association says if they had recent joint replacement, they want you to give antibiotics. This really applies for the class 3 contaminated cases, the transrectal biopsies. I push back on whether or not we need to do this for a transperineal biopsy. Other things, patients have diabetes, they have recurrent infections, they have obesity. The big one to me, and I see a lot of these patients, they're doing self-catheterization or they have indwelling Foley. These patients, I also give more antibiotics to. Or patients who come in and say to you, my last biopsy resulted in sepsis. Yeah, I don't care what I give those patients a couple of days of antibiotics just to cover them. If anything, it makes them feel a lot better. Let's talk about blood thinners. This is the bane of practice, right? Patient comes in, he's on one, sometimes two agents. You have to stop it before a biopsy. It's dangerous to do it otherwise because you know you're going to get a lot of bleeding. Whether you see it or not, you can get a lot of bleeding. We typically will hold it, depending on the agent, anything from 2 to 5 days, and they resume it always 2 days later unless they're bleeding. Rarely do you need to admit anyone for IV heparin or give Lovenox, and we defer to our primary care or cardiology in my clinic for that. Okay, we're going to switch now to transrectal ultrasonography. different ways of doing it, and I'm not going to spend too much time on this. I assume everyone knows how to do it. The key finding that you want to do is you scan the prostate and you're looking for hypoechoic lesions. That's pretty textbook. Sometimes you'll feel, the way I think about it, if I can feel a nodule or induration on prostate exam, I look for that particularly when I do the ultrasound, because you want to make sure that you biopsy that. How to do local anesthetic. This is for transrectal biopsies. Most of you are going to be familiar with this. You basically want to take the needle and you find the angle between the base of the prostate and the seminal vesicle and inject a generous amount of, 0.5%, 1% lidocaine into the area. And you want it to diffuse out along denoviase. The data, randomized clinical trial shows that when you do a injectable lidocaine, just like I described, for transrectal biopsies, you will reduce the patient's report of pain during the biopsy. That is during the actual sampling of the prostate. Many folks also use a lidocaine ointment. They put it around the anus and maybe rub it on the prostate. That does not reduce the pain for the biopsy itself, but it does reduce the discomfort patients have for inserting an ultrasound probe. You probably all have that patient, you put in a probe and they jump off the table, right? By putting the lidocaine ointment around the anal canal and going 360, that reduces that discomfort. The other thing that I teach my residents is pay attention to the angle when you insert the ultrasound probe. If you just put in an ultrasound probe and you jab against the wall of the colon or the prostate, they will jump as well. And some prostates on DRE, the angle is different. So you want to take out your finger and insert the probe in the same angle that the anal canal goes. Dr. Barocas talked about different biopsy templates. The guideline says at least 12 cores, and you think of that as your 3 paramedian cores on each side. That gives you 6, apex, mid, and base. That's how we used to do it forever. And then you could do 3 more laterally. There are different ways to do it. You could do 2 more laterally, you could do midline cores. However it is, the idea is you do the sextants and you have to do additional sampling more lateral so that you increase your yield. Most of the prostate cancer, this is more like a board exam type of question. Most prostate cancer is coming from the peripheral zone. It is interesting now that we've been doing MRI how many anterior prostate cancers, significant cancers we're finding, but generally, the teaching is still most cancers will come from the peripheral zone, and this is old data going back 20 years. There are limitations to the transrectal approach. Okay, so transrectal approach, great for picking up peripheral zone. It's right next to the colon, makes sense. But you will systematically undersample the anterior prostate and underdiagnose cancer that's at the apex of the prostate. And this is where perineal biopsies may be superior. In a perineal biopsy, the needle obviously comes in almost parallel to the rectum. You're able to sample the apex really well, and you could take your needle guide and adjust it so you're higher on the prostate, and you could sample the anterior prostate very well. On the same measure, if I were to modify the slide, I would say there are many times when we're probably undersampling the base of the prostate. So I'm going to talk about how to biopsy the base of the prostate when I show you the video. Some anatomy first. This is a standard Netter diagram. Rectum, patient is in perineal position, so the scrotum's up here. You see the GU diaphragm here. Most of the biopsy, when we do a transperineal biopsy, takes place in a very small volume of space, right about here, above the anus and behind the scrotum. It literally looks like a deck of cards. That's how tall it is, and it goes in maybe 2-3 inches, depending on how big your patient is, and it's not very wide. This is a surgical picture. The anus is below here. That's the prostate revealed in the perineum during a urethroplasty. Here is a transverse view of the perineum, okay, doing a transperineal biopsy. Prostate looks just like if you're doing a transrectal biopsy. You have to get a transperineal probe, but it looks exactly the same. You see the peripheral zone, you see the transition zone. Here is the sagittal view. Rectum is down here, obviously. Midline view, because you can see the urethra, you can see the symphysis. The prostate is here. Let's talk about equipment. If you have a transperineal probe, also known as brachytherapy probe, you need to use that versus a transrectal probe because the alignment of the crystals differ. You also need this thing that we call a needle guide, and different companies make it. I'm going to show you a couple of these. This one is made by a company called Precision Point. Basically what they all have is a carriage, basically some way of attaching this to your ultrasound probe, and some kind of needle guide that your microvasive, for instance, needle may go through, all right? And the reason why you have to, the benefit of attaching a needle guide to your probe is when you move the probe, let's say you rotate it or you angle it to the side, that needle will go with you in generally that same direction, okay? And one of the keys of using this particular device, the precision point, is make sure when you put it on, it's aligned exactly at 12 o'clock. It matches the 12 o'clock position on your ultrasound probe. Here's another device made by a company called LeapMed, Surefire. Basically, same sort of thing. It attaches onto your ultrasound probe, and for those of you who use B and K, there's a funny notch on the side of your ultrasound probe on B and K, and when this came out, I realized what it was for. This particular needle guide fits exactly on a B and K, so when you put it on, you don't worry about whether or not it's at 12 o'clock. It's exactly oriented at 12 o'clock. So actually, it obviates some of that misguide attachment. Unfortunately, this guide does not come with the needle guide. So as a separate purchase, you have to buy a needle guide that goes through it, and it comes in different sizes. Just get the short ones. You don't need this needle guide to go into the perineum very much at all. Here's the newest device that I've tried, and I like it. I think this is actually a significant improvement in how we do transperineal biopsies. And what it allows us to do, besides having a needle guide that goes different heights on the perineum, it allows you to pivot it. That's why it's called Pivot Pro. And for those of you who have done transperineal biopsies, if you want to do the peripheral zone, you may use the lowest setting or second to the bottom setting. If you want anterior, you got to take that needle guide out and you have to place it higher. Worse yet, if you're doing transperineal biopsy and you go, oh, it's just a millimeter too low. I wish I could like just get it a little higher, a little lower to get to where you want. This device allows you to just push that angle a little bit, and you just hold it with your finger. It's done kind of freehand. You hold it with your finger, and then you could guide your needle a little bit higher, a little bit lower, and it gives you quite a bit of deviation. So I think this is a great idea for transperineal biopsies. Okay, I did say before that the key to doing transperineal biopsy is the anesthesia. So here's a video of us giving a transperineal local anesthetic. The key is to look for the levator layer, which is here. Here's your prostate. The needle comes in, and right before you get to the levator layer, there are some nerves, some sensory nerves. You drop a little bit of lidocaine there, then you go through the levator layer, and you basically along the deep fascia of the GU diaphragm, you want to inject lidocaine, and that lidocaine, you'll see, here comes the needle, you'll see the lidocaine layer out over the apex of the prostate this way. So you'll see the liquid lidocaine going up, and that's what you want to see. That's a successful injection there. Now you can also do it, the different separate place where you could put lidocaine is underneath the apex of the prostate. So this is a different method where you can put the lidocaine. And here I'm not looking for the lidocaine go up over the prostate, but to come underneath the apex of the prostate. You'll see the needle come in, and you see I'm depositing a lot of the lidocaine underneath the apex of the prostate, and it'll go both ways. It'll go pretty much bilaterally, but I do inject on both sides. For those of you, and this is a nuanced thing, who also place gold markers for radiation and also put in the spacer gel, I do not use this second way of anesthetic, because what that does is kind of messes up the plane. If you need to put in your spacer, you want to have a nice unadulterated plane to put that your guide needle into and to separate it. So I wouldn't put the anesthetic this way for that. And this is just a little video about how we do the transperineal biopsies in my clinic. You begin by putting patient local in dorsal lithotomy, retract the scrotum, sterile prep of the perineum, and here you see I'm numbing up the skin with lidocaine, usually about half cc, 1 cc is plenty. Then I go in with the 20 gauge spinal needle. This is all done freehand. You can also do it through the needle guide if you want. And then once I'm through there, I basically look on ultrasound, and here we are, and I look for the levator layer. I pass my needle through the levator layer and put in the lidocaine. One of the key things in the transperineal biopsy you want to do is you want to avoid putting your needle, be it the biopsy needle or the anesthetic needle, into the corpora of the phallus. All right, probably you're going to increase your risk of ED, and the patients will always feel it. So try to avoid hitting the corpora. And then you take however many samples that you're going to take depending on your template. Speaking of templates, the template we use at Michigan is called a modified Barcel template for transperineal biopsy. This is a very, not the best diagram, this is what we use. Think of it as you got the apex of the prostate up here, the base of the prostate here. This is called the modified Barcel template, and this is the music collaborative template. The idea is you go in, take the needle, and you take the apex. So from outside the prostate to mid-prostate. For your base sample, you can stick your needle before you fire it into the prostate, into the substance of the prostate, maybe a centimeter, depending how large the prostate is. Sometimes you don't have to go very much. And then you fire the needle once it's inside the prostate, and that's how you're going to reach the base of the prostate. Okay? Let me show you a video. So here you see a needle. It's outside the prostate. Take a sample. That's considered the apex. Okay? So here you're going to see us sampling the base. The needle, this is before we fire it, and I put it somewhat into the prostate, and then I fire it. How far I put it into the prostate depends on how big the prostate is. Your larger, longer prostates, I'll put it in more. After you do a lot of biopsies, obviously, you know the travel of your biopsy needle, and what you want to do is you want to reach the base. I think a common problem if you're under-detecting cancer using transperineal approach is because you're not reaching the base as much as you could, okay? Here's another template, and we have yet to work out what is the ideal or optimal template for doing transperineal biopsy, so it's kind of the Wild West right now. Another way of thinking about the biopsy template is you just start at the midline, and you keep directing your needles, placing it around the edge of the prostate, even anteriorly, and you just don't need to biopsy the central part of the prostate. But there's different ways of doing it. I can't say one is better than the other. We don't have much data on that. The one thing about transperineal biopsy you can do that you can't do with a transrectal biopsy is you can actually biopsy suburethral lesions. All right. I used to be a big fan of doing this, and in the music collaborative, we used to biopsy underneath the urethra. Let me see if this is a video. Yeah, so here you see the midline. Here's the urethra, prostate. You come in with your needle, and you can actually come underneath the urethra and biopsy the peripheral zone tissue right underneath the urethra. You never do this in a transrectal approach because, by definition, you're going to biopsy the urethra. Patient screams, he bleeds, blood coming out the penis and everything like that. You can safely do it with the transperineal. The most recent data I saw from our music collaborative is that actually the detection of cancer directly in the midline, absent a known MRI lesion or palpable lesion, is actually very low. So I've stopped doing the midline biopsies unless you need to. So let's talk about detection. The data for transperineal biopsies done in the method that I showed you, and here's a review by Sabo a couple of years ago, basically shows that cancer detection rate is very high, 45%. Clinically significant cancer, 25%. And this should be very comparable to what you're getting on a transrectal biopsy. The difference is sepsis rate, okay, hospitalizations and so forth, very low, close to 0%. And no antibiotics in 10% of the patients in his review. Urinary retention, as I suggested, for perineal biopsy seems to be higher at 2%. And then he also talks about the cost to the system in the hundreds of millions of dollars being saved by avoiding sepsis just for doing prostate biopsies this way. Here's another paper that compares transperineal and transrectal biopsy, basically saying that in 339 patients, no difference in cancer detection for high-grade cancer, low-grade cancer, detection of high-grade PIN, detection of ASAP. It's all the same. There is data out there, and this study makes a point of it, that you do have more pain, okay? And so I won't lie, when you do a transperineal biopsy, the patients will feel the injection of the lidocaine more so, it's more painful, than if you do a transrectal biopsy for the local anesthetic. Still, even though they have more pain, we can safely do it in the vast majority of patients. Here's another study looking at the difference between detection of prostate cancer. Now we're looking at randomized clinical trials. Again, the data is pretty convincing. No difference that they could find with cancer detection between transrectal or transperineal biopsies. Therefore, not surprisingly, our AUA guidelines now says you can use either approach. Okay, if someday someone was to develop something where they clearly show one is superior to the other, the guidelines may change, but the guidelines say you can do either approach right now. So let's talk about pathology. One of the things is you do a biopsy, results come back in a few days, a week. Don't make an appointment for the patient a month out. That guy's going to be anxious, right? So as soon as you get the result, give the patient a call or do a video visit or have them in your office. So guideline statement number 19 says, communicate results with following the biopsy as soon as possible. You should also go over at that time with the patient whether or not they need more biopsies, they need more PSAs, or maybe they can stop screening. Maybe this is the guy who's approaching 80 who insisted on a biopsy. You tell him, okay, I think that was your last biopsy. You know, go over that with the patient, document it. On the same measure, if a patient, now I'm thinking more of a younger patient, has elevated PSA, you do a biopsy, don't give them the idea that that's it, that he never needs another biopsy, never needs PSA screening. No. If the patient is at risk and has at least 10 years of survival, you should continue to put him back into the pool for continued screening. It may be with his primary doctor, but do not abandon screening just because he had one negative biopsy. This is a slide. We have a number of guideline statements about pathology. In the past, those of you who are older like me may remember we used to rebiopsy high-grade pin all the time. That's different now. Clearly, if you do a biopsy and there's only one core of high-grade pin on that biopsy, say out of 12 cores, it's like any other patient. I basically ignore it. In the scenario where you have multiple high-grade pin cores, we believe that that set of patients are at increased risk someday for finding clinically significant cancer, but we don't have clear guidance on how you should manage it right now. Okay? We don't say go back and do another biopsy in 6 months, which I used to do. We basically say watch that person more carefully, maybe do biomarker, as you've seen earlier today, do an MRI, look at their risk more closely. The same basically applies if you have ASAP. The difference is ASAP and atypia. ASAP is not a pathologic diagnosis. It's your pathologist saying to you, listen, we got some cells that look really highly suspicious for cancer. We think you could have cancer there. Maybe your needle just didn't get a good enough core. Okay. Again, in that scenario, I used to go back and rebiopsy all these guys and do saturation biopsies around that area. I don't do that anymore. I use a biomarker, I use an MRI, and if those both come back as low risk, I just reassure the patient and follow them. Everybody now should be using group grading, at least your pathologist should be using group grading instead of Gleason score, clearly showing that group grade 1 to 5 correlate with our Gleason scoring system. I think this is one of my last slides. Follow up on negative biopsy, okay? After a negative biopsy, we know that PSA should not be used after a negative biopsy as a single biomarker. We know it works well for initial biopsy for detecting who's at risk. Once the patient has had a negative biopsy, PSA is terrible, so don't use that. You can use nomograms, you can use biomarkers, get an MRI, but don't use PSA by itself. Guidelines also say if a patient has a negative biopsy, put them back into the pool. And our screening, our guidelines basically say screening should occur every 2 to 4 years for otherwise normal at-risk patient between ages 50 and 69. So I'm getting to habit now telling patients come back in 2 years. And then the best way to reevaluate risk after a negative biopsy is to use a nomogram, and there are many of these available online. But make sure the one that you use takes into account the fact that patient had a negative biopsy before. Don't get one of those that don't take that into account, because that has a significant protective effect on detecting cancer. So in general, we see a trend from moving from transrectal transperineal biopsy for safety concern. Local anesthetic is key. You saw me do that today. And the templates for transperineal biopsies are not clear. And of course, follow the guidelines for all other aspects of prepping and doing your biopsies. Thank you for your attention.
Thank you so much. Well, this is all we had, and we hope you find this helpful. Everything's available online in your course package, and please fill out the course evaluation. Thank you very much.